Good afternoon, Dr. Drumright. Ms. Mac.
Thank you, Marlon. Now, Dr. Drumright, where we got to for lunch, I think, was we were discussing the merits and demerits, or the demerits and merits, as it were, of cutting up the data to look at shorter sections. And it occurred to me we should just look at those exercises. I wonder if we can go to Bundle 44, Volume 7, page 57, which should be, well, actually, let's do 56. 56 is the question I asked. What was the overall BSI incident rate attributed to environmental microorganisms among pediatric hepatology patients in York Hill for the whole period, January 8 to May 15? And then during the same period, what are the GAM fit linear plus smooth components against monthly incident rates? I think you've followed your own route for the second half to some degree, but we'll get there in a moment. So just in terms of calculating the rate for the period, I've asked you to do this for all of these periods, and I asked Mr. Mukherjee to do it too, and the answers aren't particularly different in terms of numerical value. Now, again, remember the lady, would you agree with that?
I would agree with that, yes.
So, but is it an exercise that's worth doing, calculating rates for relatively long periods in order to see if artificially putting a change point in has a change?
So I would argue that's two different things. I'm going to split that up.
Yeah.
So the change point, putting the change point in, I'm happy both to let the data put that in and for us to explore that. That is slightly different than aggregating all of your data over a long period of time. So when you do that, right, we are interested in peaks and troughs, and we're interested in what is noise and what is real in those peaks and troughs. So when you collapse all your data over that time period, you just lost all that information.
I just wondered if it was in any way related to the output in volume 5 of bundle 44 on page, say, 52, where I appreciate the data has told you the change points, but it is also collapsed between the change points. And so whilst you'd have to be aware that in the other attempt, we imposed the change points, or I imposed the change points, can we gain any information by looking at that landscape of rates between change points and the imposed landscape of change points, and thinking, are they similar? Are they different? Is it telling something?
Yeah, I mean, I understand what you're doing now when I look at that. I think there are nuanced differences where this is a slightly statistically more palatable way to do it with the change point, because it's taking into account the noise, it's looking over time, and then it's giving you an estimate for that time period. What we are doing is just collapsing data down. So it's not quite the same thing, but you know, I'm happy to go along with this as sort of an exercise of reasonable interest.
Well, what we'll do is we'll move on to the chart itself. So back to volume 7, page 57. Now, you narrated on 57 what you see in the chart below, but perhaps you could just explain to us, albeit I set the period, what this chart may or may not show that is significant.
Yes, so again, these are the exact same models, the GAMs that I used previously.
And they're the same as the long chart 2F2.
Exactly.
Yeah.
I didn't change the model, I just changed the time period. And of course, because it takes less time and this was a much more rapid exercise, I didn't put in those confidence bounds on that line. And if I'm just revisiting, the p-value for that linear trend was not quite statistically significant is what we're looking at.
Because if it was statistically significant, it would be
0.05 or less. Yeah.
And
So
it comes out at 0.07.
yeah, so you know, this is a little bit, this is where we're kind of on the edge, right? So when you study statistics, people say, surely 0.06 is as good as 0.05, right?
Yeah.
That's an arbitrary cutoff that we've set in the world of statistics. So something between 0.1 and 0.05, it's not statistically significant, but you might think that's interesting.
And does it have any connection to that downward trend linear component that ends in 2013 that you found in the earlier chart?
It does. And so what I might say looking at this is we chopped up the data and that took away our power. This is probably a linear significant trend because that is what we see when we
Right.
have the full power of our data set.
So if we go on to the next page, where the period, same question was asked, but now from move to decant. Now, you've explained, you calculated a rate that's 4.7 as opposed to 4 and a bit. So it's not much different really, is it? But of course, there's a big difference in the time. Would you agree with that from the beginning to the end here?
Oh, absolutely. And I believe both of those are statistically significant. I'm just double checking. Both of those lines are statistically significant, and there is a very big change. It goes from very, very low to fairly high. And what I would trust is that red line as your beginning and ending, not necessarily that blue line. And that's because that red line is our smooth line, and we know that's statistically significant.
Right. And because it's statistically significant on the other chart.
It is on the other chart as well.
Yeah, exactly.
Yeah.
And how much weight should we take from the impression that might be here that there is a steeper growth in early 16 than later on? Is that something that's of worth note, or is it just too fine to worry about?
I would be careful of that interpretation. I would just say what this is telling us is that there is a definite significant increase. There is some wobble in that increase. So I guess what you're saying about the steepness is you're going above that blue line and now you're going below it, right?
Yeah.
You're saying it's coming up a little bit. I would believe that trend. That is a smoothed trend. So again, I would take it lightly, as I would with most statistics on retrospective data analysis, but it certainly is telling us something, and it certainly is consistent with our change point analysis, and it's consistent with our GAMs from the
long chart to F5, right.
And all that is good. Consistency is always good.
Yeah, so we go to the next page, just to keep up the topic. We calculate the rate for this shorter period from September 18 to February 22. Now, I appreciate it's a much shorter period. So am I right to hear your anxiety about the period much more loudly at this point?
Yes.
Yeah. But the rate that, for what it's worth, you calculated was 2.8, and that seems lower. Is there anything that we worry about that interesting, or just put it in the pocket and worry about it later?
Yeah, I don't worry about that being lower. What I am slightly concerned about is that I think we're missing a downward trend that is happening in this time period. But
and in fact, the next page, when we ask you to do the whole period of new hospital, firstly, is this period more useful length, or?
Yes, I would definitely say that. And
I'm going to ignore the rate because it's up and down, but what do you feel that this chart this exercise is teaching us about can it teach us more than the long chart 2F5?
So I don't feel it does. I feel it's showing us a very similar pattern as the other one. And it's fairly consistent in even where we see, the upward trend and the peak of the curve there. So I think that this is basically showing a scaled down version of.
Right. And in fact, you put the chart on the next.
Just give me that again. Showing a scaled down
version of the long chart with all of the data from 2005 all the way through 2022.
Which is 2F3. I've been calling it 2F5, it's 2F3. And actually you've repeated on page 61.
Yes.
On the next page, please.
Yeah. just to make the point.
Now, I do want to repeat the question I'm about to ask you.
Can I, with apologies, can I interrupt? Again, it's really just my noting. When we were looking at, I think, yes, it is figure 2.6. I noted you as saying
Page.
Go back
it
to
shows a downward trend, but you miss some of the trend. Now, did I?
59?
Could we go back to 2.6?
Yeah.
Page 59, please. Thank you.
Oh,
I-
so with this one, if I was reading up above in 2.5.2, this line is not statistically significant for the linear trend. So what that is saying is that's essentially the same as a flat line, even though we're
Okay.
seeing it go down.
Right.
It could be the same as a flat line. And what I'm saying is I don't necessarily believe that. I think it's still going down.
Right. So
I think
sorry
it's
to
a
be
power
so
issue.
sorry to be so slow about it.
It's all right. I think it's a power issue. And these are very difficult concepts. So don't worry. Please feel free to
Is
ask.
it because it's a shorter period of time?
Because
and
it's a
less points?
shorter period of time, so the idea of power, the more observations you have, the greater the power. This period of time is really short compared to all the other ones. And so we've lost a lot of power. And of course, we have a lot of noise you can see in there. And it can't make a decision, the model, that there's a difference between noise and trend.
Now, what I'd like to do now is to look at a chart that Mr. Mukherjee calculated
Okay.
using, I think, your data or a very close proxy of it.
Yeah, I think he used it. I sent over the data,
Yeah.
as you recall.
So this chart is in his report at the same time. It's the same bundle. It's page 47. Now, he hasn't used GAMS, and he hasn't, you're shaking your head, and he hasn't used negative binomials.
No.
He's done linear trends.
Yes.
But what I wondered whether this exercise that he's carried out, in a sense, adds anything to your understanding when viewed alongside the charts we've just been looking at.
I would say no, and I would say no mostly because I'm being a bit statistically difficult. This is not just a linear model, like a general linear model. This is a this is a linear regression, and it does not meet the assumptions of a linear regression when you have that many zero time points. So if this was a GLM, where he was looking at linear sections, it might be of greater interest, but I'm just concerned that the model is incorrect.
In a sense, the flaw in picking this linear regression model is because there are so many months for most of the period with zeros, it gets confused by those.
Yes.
And the same would be true if it had lots of very high ones as well.
Yes.
It's the extremes are messing it up.
Yes, and with linear regression, zeros are a particular problem. So if you go back to the models, right, if we go to a generalized linear model, that's different because, as I mentioned, the families before, you get to pick the family, which is telling you something about the underlying distribution of the data. And the underlying distribution of the data in a linear regression assumes a normal curve. And with counts, you don't have
Because time doesn't pass in like normal curves.
Yeah, no.
In a sense, in a normal curve, it would be like the population. You'd expect
That's
a normal
right.
curve.
That's right.
But events happening over time, there's no reason to think they would follow a normal curve.
That's right. And you have, with something like this, thankfully, you have a lot of zeros.
Right. Okay. So go back to page 61 of the same bundle, and I ask my plea for help. So if we go back to the evidence we discussed before lunch, the start of the dip. So my colleague can zoom in so that 14 to 16 is a bit bigger for the benefit of anyone watching this on the YouTube feed. Now, we discussed the bigger dip, the dip starting in early 14, and I think you accepted that it might be a real thing, or it might be somehow an artifact of the process. Now, we can come and look at evidence from the real world later, but Does what you've just done help you understand which of the two it is, or are we still slightly mystified?
Yeah, it doesn't help me understand
help.
that, because we basically put our cut right kind of in a critical spot for that dip. And remember, I told you we lose power on the
Okay.
ends.
Right. So what I want to do is to take that off the screen and look at the non-environmental stuff that we did. I asked you to do. And I think I know what the answer is going to be, but it's page 62 of the same bundle. So we simply asked you to cut at the change. Does the exercise that we carried out on this page 62, which shows a plot in the York Hill, and page 63, which shows a plot at the new hospital, does that help you understand any more than the previous chart?
No.
No. We go over to the next page on page 64. Now, it's gone a bit sad, so we'll go back to bundle volume 5, page, I think 52 it is. Hopefully we'll see its happier friend there. I think it's page 52, at least I hope it is. Definitely not. We take that off the page. Bundle 44, volume 5. 51. Yes. So we're back where we were before lunch, right? Now, what I wanted to do is to think about, go back to our conversation about the two scenarios that you were presented with and the counterfactuals. And if I remember where we got to, there's the contaminated water system scenario, which at the time you wrote the report you didn't know the dates for.
Right.
There's a ventilation scenario which you didn't quite know the detail of, but you knew it involved air changes.
That is correct.
We have the CLABSI counterfactual. We have the nursing single room counterfactual. We have the Teams counterfactual with the antimicrobial resistance counterfactual, and maybe have the lab capacity counterfactual. That's the list.
That is the list.
Right, okay. I'm trying to think of a way of asking you a sequence of questions where we gradually introduce evidence from what actually was going on, if you
Yes.
can use that, outside the data. And either you can tell us what you think it is going on, or if you're concerned that you don't actually have enough information because you've not been given access to it earlier enough, you tell us what to look for.
Okay.
So what I thought we could start with is to try and understand from your point of view what the mechanisms are of the counterfactuals and the scenario. So we'll start with the laboratory, and take that completely off the screen, please. With the laboratory not working as efficiently now. If that was going to affect the rates of either the environmental or non-environmental groups, what would be the mechanism?
So this is the most complicated one, I think, in terms of what would be the mechanism. And you could see a wide variety of issues. So you could imagine that, for example, the laboratory is contaminating the samples when they come up.
Right.
So this is one problem you could have, in which case you're going to largely see, but not entirely, non-environmentals, right? Because most people are contaminating
because actually the number of
hands.
samples for non-environmentals is much higher.
Yes, and so that could be, again, like I said, and maybe we shouldn't call it a lab issue. Maybe we should just call it a contamination issue.
Right.
So that could be happening with the nurses. It could be happening up at the lab. Whoever's drawing blood, whoever's handling the blood. That's one issue.
Before you move off that, would that show any temporal change? I mean, if your lab system wasn't brilliant, wouldn't that just be the same over a long period of time?
Yes, if everything stayed the same.
Yeah.
But if you had problems like you were understaffed, for example, or your staff was in training or something like this, then you might see it for a period of time and it might go away.
Would we expect to have heard that from laboratory microbiologists and lab scientists who are giving evidence in this inquiry?
I would hope so, but
Depends
I
what you
can't.
ask, right?
Yeah, I can't give you any more information than that. I think that is That was not on the original counterfactual list because I think it's the most unlikely scenario.
Okay. Let's move on, and we'll not do this in too much detail, to antimicrobial resistance. What's the mechanism that antimicrobial resistance would affect the environmental group and or the non-environmental group? How would the mechanism work in your understanding?
So I am going to ask you to get details on this from my colleague, Dr. Agrawal. But in general, there will be antibiotics that can drive up cases of certain types of microorganisms. And a lot of those, as I understand it, are environmentals. And so if you start using more of those prophylactically, particularly, you end up seeing a whole rash of new cases in certain environmentals.
And would I be expecting to ask Dr. Agrawal about how that counterfactual hypothesis connects to prescribing patterns or the number of microbials that were in the sample? That will be the connection.
Yeah, I think he could probably look at the chart, the graph that I've produced, as well as the other information that you have.
And if we have a chart that shows the incidence of meropenem resistant bacteria over time, he'd be able to look at that, wouldn't he?
Yes.
Yeah.
Maybe this is just to state the obvious. If one was testing the hypothesis that the choice of antibiotic was affecting the total population of potentially pathogenic microorganisms, one way of at least taking your investigation further would be to find out what was actually being prescribed over particular periods in particular patient cohorts.
Yes, that would really help.
Okay. If we move, and so have you been given any, other than that report that turned up in the folder which you hadn't seen before, have you been given any reports about prescribing patterns in the hospital?
No, no.
So then we move on to the team dynamics one.
Yeah.
How would, I recognize this is how long is a piece of string type question, but how would team dynamics affect these two classes of infection rates?
Yeah, so given that they both go up, and that's very important, I would expect to not see a huge difference in, I wouldn't expect environmental or non-environmental to go up and the other ones stay flat with team dynamics. So just to make that clear, it's because they're both going up.
But they go up at slightly different times.
Yeah, and that doesn't bother me so much because, of course, if you've got care issues, you're likely to see your non-environmentals first because it's so much easier to get a bloodstream infection from a non-environmental. So everything that's on your skin,
right?
That's everything from inserting the line to managing the line. There's a whole host of microorganisms that are very good for us waiting there to become opportunists with a line. So you expect to see them go up and come down first. So if they have a problem, you'd expect them to go up first. And if they manage that problem, you'd expect them to come down first.
So we turn to, I'm wondering at this point, the way you talk about it, I'm wondering whether the line issue and the nursing issue are actually the same issue.
They could be the same issues. So patient safety issues related to dysfunctional teams, poor handover, disagreement, which means that a policy doesn't get brought down to the group from one of the management positions, other things like that. So these are the types of errors we see happen, particularly, as I said, with handover or with not implementing policies or that sort of thing, or people feeling like they don't need to because there's a discussion about this person's policy, this isn't very good, I don't like this. So then an interpretation that, from the other ranks that
people
I don't have to
don't do
this.
things consistently, they don't follow instructions.
Yeah.
Did you read the Case Notes Review Overview report?
Can you,
So I'll put it on the screen. So it's Bundle 6, Document 38, page 975.
yeah, I don't believe this is one that you pointed me to, and I don't believe I
Well,
read this.
it's the subject of the criticisms by the HAD report in Chapter 4. So you signed the report. So did you read the document you're criticizing?
So no, this is that was Peter's, Professor Hawkey's.
I appreciate
Commentary.
that, Dr. Drumright, but you signed a joint report in which you criticized the Case Notes Review and suggested we should ignore it. And we had Case Notes Review authors provide a rebuttal document, and
Which I did read.
yeah, and they took a lot of time to do that, and no doubt that cost time and money. And I need to ask you about Chapter 8
Okay.
of this report. Did you read it?
No.
No. So Chapter 8 of the Case Notes Review Overview report describes their areas of concerns about, well, I can give you the headings because that might be the easiest thing. The area of concerns around data, managing infection control outbreaks, microbiology and IPC systems, clinical records of all sorts, adverse event reporting, morbidity and mortality reporting, line care, and other aspects of clinical care. So have you read that criticism?
No.
No. And then the other groups we then move on to, I suppose, is into the two scenarios. So I'm going to leave the mechanics of ventilation to Dr. Agarwal.
Okay.
Do you see any connection between ventilation and the water and the environmental BSI that you're looking at in this chapter?
No.
No. If we look at the water scenario, now, when you wrote the report, did you know when the interventions took place?
No.
No. So when do you understand there to have been interventions?
So all interventions or just water interventions?
Yeah, water interventions. When do they start? When do they finish? What's the exciting
So
ones?
it was early 2018, I believe it was March, when they started concern about water, when the concern about water was raised. In April, there was an intervention, sort of April, May, June. There were a series of interventions from, and I can't recall which matches up with which, but they first removed the taps. They then change out filters. They worry about drains. They dose drains. And then at some point in 2019, they're not satisfied. They want to look at the ward more, and they move the patient.
So just to check, could it be that they don't remove the taps? They put filters on the taps.
Filters on the taps.
They check the drains a lot. They dose the system 2 or 3 times. And then in September of 18, they move the patients.
Okay, yes, that sounds
And then in
accurate.
December, November, they turn on a chlorine dioxide dosing system, which feeds the water for the whole hospital, chlorine dioxide as a treatment agent. Is that consistent with what you think you read?
Yes,
Right.
yes.
Now, if that was, what would be the mechanism by which such an intervention would be seen in the data?
So what I would expect to see is that if that was the only intervention that was in play, right, that the cases would remain high, and it would take a little bit of time, maybe 2 months, maybe 3 months, to start seeing those cases go down.
I appreciate you said if that was the only intervention.
Yes.
So having gone through the other point to mention is, imagine you have a water system which is being managed in a less than optimal manner for a number of years, and then in April 2018, the senior water managers of the hospital decide that there is contamination widespread through the water system. Now, whether other people later disagree, that's what is recorded in minutes. So the assumption there, and this is entirely an assumption, that if there's something to be found in April, it was probably there for some months before. Now, if there was something wrong with the water, and that's an if, I appreciate, in, say, the 6 months or the year before April 18, again, If that was the only cause, how would you see that in the data?
So in the data, you would again expect in the, when it starts, and you hypothetically put that 6 months before April, you would probably see a small increase that goes up over time. And I would think that would lag the time that it started by a month, 2 months, maybe even 3, depending on the mechanisms of how these microorganisms are. So now we're making a huge assumption,
Yeah.
right? That the microorganisms from the water are getting into the patients and causing bloodstream infections. So the mechanism for how that's happening, there will be a time lag for
So
that.
if we, again, big assumption, set a scenario up, we have a date, which we don't know when it is, but there's a date when the biofilm, I think is the word, gets to a point when it's causing it to slough off. And we've been told by some people that the risk is that it comes out the taps, it gets into eyes and mouths when washing the teeth and things. It gets when you have showers, it gets into wounds, it gets onto things that are cleaned, including hands. And your position is that within a few months of that date, whatever that date is, that is when you would see a slow increase in the data,
And
if it was the only cause.
Yeah, and you would probably see certain microorganisms come up first, right? So there are organisms like Pseudomonas that hang out, in these biofilms that sort of get everywhere and create problems. And then you might see other types later on. I would expect to see a little bit of a pattern with the microorganisms as well.
Now, so I want you down to the mechanisms, and I appreciate we then have that you've got some caveats in there. So we then move to, I suppose, extreme positions. And what I want to do is ask you for each of these, start at the bottom again, whether you can exclude them having no role at all, based on the data you see, or being 100% responsible. So it's excluding the extremes.
Okay.
If it's in the middle, then obviously we'll do that in a different
Okay.
way. So if we look at the lab systems contamination story, could that have no role at all, or be 100% responsible? Could it be at the extremes on that in that sense?
So if it exists, is that what we're saying?
If it exists.
No, I don't think it fits either extreme.
Yeah. So it either doesn't, it can't be nothing to do with it,
No.
and it can't be everything to do with it.
That's correct.
Right. And if we do the same thing for antibiotic resistance,
Again,
I'm assuming that given that not all antibiotics are affected, it can't be everything.
yeah,
Right.
exactly.
And if we move to dysfunctional teams, I mean, the team can't be that dysfunctional, so it can't be everything.
Of course not.
No. Can it? If you think about line safety and the nursing and the single room, if we sort of fudge them together a bit, could that account for everything we see?
So this is a very tricky question, and this is why I'm pausing. If we now make another assumption that it is only the things that we can attribute to being acquired in the hospital, it could. But remember that people can carry for years in their gut one of these microorganisms, and it can translocate. Right. Yeah.
Okay.
So it can.
I should rewrite my question about the 100% is 100% of acquired in the hospital.
100% of acquired in the hospital.
Could the line safety, nursing, room thing issue, could that cause 100% of that part of what we see that is acquired in the hospital?
I think it's unlikely, but it is the most likely of all our sets of things. So it is the one thing from all our counterfactuals plus the water that I think is most likely to be responsible, only because this is what we know happens with bloodstream infections.
But you haven't studied the actual experience from the
That's right. And so I cannot say one way or another, and I don't think any of these would be 100% of what we see.
So let's move to this water scenario. I'm going to pass ventilation to one side. So again, holding your caveat that there's going to always be some that come from outside the hospital.
Yeah.
Of that unknown proportion that come from in the hospital, given what we see in both the environmental and non-environmental, could the water cause all of it?
No.
No. And why is that?
Well, for starters, we see our non-environmentals. Those don't come from the water.
Yeah.
And it's just, there's not a lot of biological plausibility with that water could cause this entire increase. So you have a small number of microorganisms in the water.
So why do you say a small number of microorganisms?
Well, so it is think of it this way, it's a large pool, right? If it's growing in the tap, for example, you
Yeah.
have a lot of microorganisms there. But when you turn on the tap, you have water flowing through that, right? So that's going to make that diffuse. You're diluting them. And we live in a world with microorganisms in the taps all the time, everywhere, right?
Well, what if it's in every tap?
There are microorganisms in every tap.
So you don't see a problem with that?
Oh, I do see a problem with having.
No, I don't. I didn't mean problem in that sense. What I meant to say is, if you had a hospital, hypothetically, where biofilm was a problem in every tap, and maybe in quite a lot of dead legs, and
that is going to
extreme
cause
parts
a
of the
problem.
system, you're saying that even then that couldn't cause the non-environmentals, because that's just not how it works biologically. No, right. So what I want to do now is play with dates.
Yeah.
Because if we go back to bundle 44, volume 5, and page 50, well, yes, let's start there.
Sorry, my fault. That last question related to non-environmental.
Non-environmental.
Yes.
The non-environmentals cannot be caused by the water,
okay.
even if the water system had a problem in every single tap and all over the place.
It is highly unlikely that the environmentals are being caused by that.
Why is that?
Because predominantly you'll see Staph aureus in here. That is coming from the patient's skin or from someone's skin, because that's where it resides. It doesn't survive in those environments, right?
The watery environment.
Yeah, that's a low nutrient environment with water. That's not where it resides. And if you want lots of details about these microorganisms, I'll refer you to Professor Hawkey. I'm sure you'll ask him lots of questions.
So what I want to do is I want to look at, go back to page 50 on bundle 44, volume 5. Now, I think I need to have a final go at the dip.
Yeah.
And so I'm going to enlist the help of Miss Cairns.
Okay.
And visually, I'm going to take you to volume 7, bundle 7, document 6. Page 230. Now, just the top half of the page. So this is a chart produced by HPS using their environmental including enteric group. Now, Ms. Cairns' position that this is the closest analogy to your group, albeit it's not perfect. And so she's also given evidence, as has Ms. Imrie, who are part of the writing team, that you'll see how this chart plots a rate per 1,000 occupied bed days on the y-axis, time on the x, from mid-13 through to late 19 when it's written. The blue line is an average, but that average is driven only by the data before the move to the new hospital.
Okay.
And then what they've done is they've pointed an upper warning limit at two significant differences. At the point when it's the upper warning limit and the upper control limit at the second and third significance threshold. I've forgotten the exact word, but it doesn't really matter for the purpose of my question. The reason I was interested in this chart is it contains data for the 2 years before the move. Now, it's just raw data, it's monthly, it's rate data, and visually you can see that it's bouncing around that short average from before the move. And so what I asked Ms. Cairns to do was to do something that you don't like, which is to smash it all out and get some rates. And so she did that in and it's in bundle 44, volume 6, at page 20. And what she wanted to, and that this chart is the same data as that table,
Mm-hmm.
and the chart we looked at, figure 6, is the second big column from the right. Do you see how you've got 4 big columns at the top?
Yeah,
gram
it's the
negative. So they each have a
environmental.
figure in the chart, and then in each chart table there is a cases and there is a rate.
Yes,
And it's smished, as you say, it's averaged across the period, so you lose all the detail.
yes.
And I asked her to, in a sense, mimic you, and she calculated a rate in York Hill prior to the move for those of 2.55. And then I asked her to count the rates each side of the decant, and she didn't like that very much because the third period is rather short, and so decided to calculate the year after the move, when there were all those zeros,
Mm-hmm.
and came up at 0.91. Now, if we go back to bundle 7, and that chart in figure 6, I appreciate this is very short ranges of data, and it was done live at the time, and I think NSS are quite keen for us to remember that. This is a dynamic piece of work done to support the IMT. But is there anything in here that helps us understand what's going on immediately before the move, and that the start of the dip, this problem I keep putting back to you? There is actually a similar one in Dr. Kennedy's work, which you might be looking at, which is bundle 6. So bundle 6.
Before we jump over there,
Yeah.
can we look back at what Ms. Cans did most recently, that table?
Yes, of course. So that's bundle 44, volume 6, page 20.
Because when I did look at this is one of
Yeah.
the items you had me look at. I was struck by the fact that it is following a similar pattern to
Yeah.
what we're seeing with that dip,
Yeah, but
potentially.
the dip. Well, I'll come back to the point I want to make when he was seeing Kennedy.
Okay.
And so Kennedy was a public health doctor who was asked to produce a report by the medical director in 2018, and his report is in bundle 6, starting at page 95. But I want to show you the image, the page 96. He called it selected gram negatives. Now, the selected gram negatives were the ones that matched the Cates definition for the IMT this was produced for. So it's a much tighter list than yours, and it's possibly not entirely directly comparable. But his evidence was that this chart and its subsequent chart the following year showed 3 peaks. 2, which I'm not worried about today. I mean, one's in 17, one's in 18. But there's one in July to September 13. And what I wanted to do, if we go back to your long negative binomial chart at page 51 of bundle 44, volume 5, is does this sort of contemporaneous, sort of small scale, possibly quite quick and dirty data help you understand whether that dip is starting in early 14 because it's an artifact of the GAM, or because that's when it's actually starting, or is it actually just dealing with the fact that there's a change of system into a new water system on the moon? And actually, although I'm very bad for keep pushing this as a possibility to you, that actually the change is the move. That's the point of change. Does that help you do that, or am I just putting words in your mouth?
So if I understand you correctly,
Yeah.
and please clarify if I don't, are you saying that there is a water system at York
There is.
Hill, and it's probably old because that's an old hospital, and it could have all sorts of, nobody tested it, so we don't
No
know
one really
what's
knows.
in
We
that
haven't
water.
got evidence on that.
And then you're moving to a new hospital and you're making an assumption that the water is clean when they get there and it's not been used.
No, I'm making an
and
assumption that it's not necessarily the same. I'm just
the
assuming
water
that
is just different.
it's different. I'll rephrase that. Is it reasonable to say there is a chance that there is going to be a change just because there's a change? Not better or worse, just different.
That's probably beyond our ability to hypothesize against the statistics we're seeing. I mean, we could say, so if we're throwing out like counterfactuals.
Yeah. Because there's no counterfactuals apart from the single rooms, and
Yeah.
that is important.
Yeah,
They obviously have a change point here.
I mean, if we start talking about counterfactuals, why there would be a change point there, maybe it's just moving to a new environment, maybe it's single rooms, maybe there's extra attentive care being taken to the patients because of the move. I'm just coming up with ideas now about.
Yeah, but if we have evidence that weren't shown about, well, you've now seen some of it, about how the CLABSI issue emerges. We should probably talk about the CLABSI evidence. So you read Jennifer Rogers' statement.
I did.
And I think you might have looked at a chart that she produced with
Ian Kennedy.
where's the document list? But you read the Jennifer Rogers evidence.
Yes.
Now, what I'm wondering here is, if we start with a non-environmental, that's the next page, please, page 51. Do we see any reason to think that the story that is described by Ms. Rogers might be contributing to this non-environmental curve and the way it's behaving?
Yeah, I think that her story could suggest both curves in that so if they aren't actively monitoring, and I'm not sure how actively they were monitoring because she doesn't start there, right? She says someone noticed in early 2016 that there seems to be an increase in bloodstream infections. I think the CLABSI infections, and then they start monitoring it quite intensively. Usually when you're not monitoring things and you sort of get a clinical feeling for them, it's after they've started quite a while. And so you could say, well, and if we want to play the game of percentages, a lot of that could be due to them having a problem with their line handling.
So I suppose that brings us to the crux, the crunch, as it were. I know you didn't read the case notes review, and we can't rely on this number because we can't see the workings. But in many ways, it might give us an upper limit. The case notes review say, if I can remember correctly, that 30% of the cases they looked at, all of which were in the environmental side of your chart, were more likely than not to have an environmental connection. Are you aware of that?
I'm aware of that. I'm not aware of the evidence they put to each of those.
But the reason I wanted to pick on it is just to pick as a upper limit. And then you'll be aware that it's the position of Greater Glasgow and Clyde Health Board that only 2 of all the cases can be associated with the environment. I suppose that's a lower limit.
Yes.
And you've just given evidence that of the non-environmental cases, quite a high proportion might be related to line safety.
They might.
And about 10 minutes ago, you gave evidence that we should remember that in both groups, there's always going to be a chunk that's brought in from outside.
Yes.
And so what I'm wondering is, I appreciate you explained you're not involved in what can only be described as the disagreement between Professor Hawkey and Dr. Agrawal in the case notes review, but there does seem to be a disagreement. But could I put this to you, that what we see here is consistent with, not just in page 51, but in page 50, is consistent with the CLABSI having an impact on non-environmental, the water having an impact to some degree, possibly in that lower third range, on the patient for the environmental. I mean, not nothing, but not 100%. and then gets brought in from outside also has an impact. Is that broadly happy position to be in?
Yes. Yeah, I would agree with that. So remember that environments, regardless of whether or not we see them as, extra contamination in water or just the normal amount that you get from water coming out of, the mains that you're given, it's part of the environment, right? That's where people would pick up environmental organisms. It's just a matter of, is it the hospital? Is it at home? Is it, so there's no question that the environment plays a role.
Yes. I mean, I wonder if we can take you back to the HAD report and to page 118 of pod 44, volume 1, where I think you reach conclusions on what your chapter shows. So, yes, page 118, please. So, figure 22 is at the top, and then we have a heading. I appreciate you didn't write the headings. Evidence of environmental contamination, in particular the water supply, based on bacterial data from hemato-oncology patients in GTC. And in summary, the historical data from GTC hemato-oncology services provides a background into prior incidents and cases of bacteria attributable to microorganisms that could be environmentally relevant. This allowed us to evaluate cases and incidents of the Queen Elizabeth relative to the same or equivalent services for hemato-oncology within the local Glasgow region. Now, was that actually what you were doing in 7.2 for the children?
Yeah, and I think that more specifically, we are talking about, could the environmental data explain everything? Does it show that there is an increase and is explained by the water?
But is that the question you were asked? Because if we go back to Dr. Agarwal's instruction letter, which is on the appendix on page 242 the same bundle, the question 5, which is the one you were asked. 5A is the water testing results consistent with there being widespread contamination? Can you explain how you tested that without knowing when the widespread contamination was supposed to be there?
Yeah, and I don't think that was tested. I think we really focused on, is there an increased level of infection consistent with widespread contamination?
Without knowing when it is?
Yes, well, we were given the impression that it was from the beginning.
Because if we go back to page 118, there's a series of bullet points, and I really want to understand whether you currently accept them. So the first bullet point might seem to be a truism, but hemato-oncology patients across services have an expected yet very high risk of bacteremia, and cases are common in this patient population. Would you agree with that?
Yeah.
Among hemato-oncology patients, including comparison of historical and current services, both incident cases of bacteremia attributed to environmentally relevant individually or taken together are statistically similar between the two hospitals. Would you agree with that?
And I believe we're looking at adults right now, right? Because I've got
this is adults, you think? Okay.
this is
right. So would you agree with that?
yes.
Right. And is that in a sense because apart from that spike in 2018, there was no difference?
So for the adults, there isn't much difference. We didn't go through that in detail. And for the pediatric, I would definitely say I would revise that bullet
Well,
to say,
it's over the next page. We might want to look at it.
okay.
So go to the next page.
No, that's the first one's adults.
Yeah, the second one also, we've discussed how they weren't exposed to the water. So the second one is, and does that help us understand if it's true that for the most vulnerable adult patients in the service, bone marrow transplant patients alone, there was a continued decrease in incidence over time following transfer of the services from the Beatson to the north sector of the Queen Elizabeth?
Well, understanding that they received the intervention water, if that's what we want to call it, right?
But they never received the widespread
Yeah, they
contamination.
never received the contaminated water, if that's what we're
So what I'm
calling
wondering is that when that bullet point really helps us.
What it helps us in saying is that certainly what we expect, so if we had the South patients to compare, What we do expect is a decrease in this population if water isn't contributing, right? Because this is our patient population that moved from north to QEUH and did not receive, as you've stated it,
Yeah.
contaminated water.
So there wouldn't be a change, or it would get better. It wouldn't get worse.
Yes, it certainly wouldn't get worse. It would
Right,
get,
okay.
it would get, I would hope it would get better because that's actually what we're seeing.
Right. And then the second bullet point, among hemato-oncology patients, we see, pediatric hemato-oncology patients, we see around twofold decrease in incidence in cases of bacteria attributed to environmentally relevant organisms following transfer from York Hill to Queen Elizabeth.
And this is the one I'd edit.
So how would you edit it?
I would say from the beginning, right before transfer, to the very end of our data set,
Yeah.
we see that twofold difference, right? And that's shown in our line of decrease. But in the middle, there was a definite increase in cases.
And would you give that
acute
increase a
period of
period of time it happened?
Yes, I would.
Well, what would that period be?
Can we go back to my graph?
Well, we can jump one page back to 118, or we can go forward to the
Can we
to the GAM one instead.
Can we have the GAM one
Yeah,
instead?
so that's volume 44, volume 5, page 50, I think. No, yeah,
page
it's 50,
above.
yes. There we are.
Yes, I would say the increase was from roughly, and I'd have to look at my analyses, that looks like about March 2016 through to, I'm gonna guess that's August 2020, but I have the dates in there. I'm just March to September, no, March to,
I think it might be.
oh, I only called the downward trend. I'm sorry. Yeah, so there is a downward trend from January 2018.
But the increase is the second quarter of 16.
Yeah, there's an increase, if we're gonna do this by increase and decrease, there's an increase from March 2015 to January 2018.
2015 or 16?
16, sorry. And then there's a decrease from 2018 to a fairly low level in what we would like to see, right?
Right.
As an overall decrease.
Would it come to any surprise to you that Mr. Mukherjee's position was we saw an increase from the second quarter of 2016, reducing again in 2019?
No, it's a little late, the 2019, but it's not a surprise.
Right. Now, I haven't discussed clustering with you.
No.
Because I was a little confused. So you carried out a clustering exercise in the report. Was that your work, the original one?
So I did the work. It was suggested to me. I was never a fan of doing a qualitative sort of thing, but I was a willing party in working on
So
that.
what's wrong with doing the qualitative clustering exercise in the HAD report?
So the problem is, there's nothing wrong per se with qualitative items, right? You see that a lot in, root cause analysis and other things, right? You interview people, you find out what they think is going on. This is all very qualitative. There's nothing wrong with doing qualitative things, but I'm not sure how much it helps, because what we're saying is, okay, this type of organism we see in this month, we see it in different wards, we see it in the next month, and then we're sort of setting a case definition for how close together in time they can be and what we call that. And so whilst that might be interesting, so let's take something like Klebsiella, which is one of our very common organisms that we see. There's no information for us that those are clonal or truly clustered, right? They are occurring together in time, as we're calling them clusters. And it's probably, you notice in the rebuttal, I move away from the concept of clusters. I don't actually really like that. They're runs. So things occurring closely together. It doesn't mean that they're related at all.
The reason I asked that, I'm intrigued at the idea that you had some concerns, and then you did this entirely statistics-based exercise, which is literally the numbers driving it, if I understand correctly.
So the GAM, you mean? Oh, you mean this next one?
The
next
clustering
one.
exercise, yes.
Yes.
So that's basically just the numbers drive the process.
Yes.
Yeah. So sticking with the report contains a statement that we shouldn't, well, let me find the exact words. At the end of the introduction of the report that you signed, on page 17 of bundle 44, volume 1, it says, page 17, yeah, it says, a significant reliance appears to be placed by the Queen Elizabeth University Hospital and the Royal Hospital Children, placed on the case notes review, in relation to whether the built environment at the Queen Elizabeth and RHC pose an increased risk. However, we do not consider the CNR is of assistance in determining this for the reasons set out below. You didn't read the CNR overview report. How could you sign that?
Yes. That was from Professor Hockey.
Because what's worrying me about is what to do with your latest statistical methodology, because your report was produced. I appreciate that it went through a procedural journey to get into the inquiry. We instructed you in February, March. We sent your report to the case notes review authors. They wrote a rebuttal, which they hadn't done before. And then you've done a completely new exercise, which they haven't seen. So what am I supposed to do with your completely new exercise? Did you read the case notes review before you did your completely new exercise?
No.
So can you give me a reason why I shouldn't just put it to one side as an exercise carried out entirely in the dark without looking at the people you're criticizing? Or are you not criticizing the CNR?
So I am personally not involved in criticizing that. I would ask you to direct those questions to Professor Hockey. I think he has a very clear set of arguments that he's interested in. I would say the new analyses that I produced were largely in response to valuable commentary from Ms. Kantz.
Right. Now, if we go to your new analysis, which is in the overview report, I mustn't forget where I am. I'm going to put a marker in here before I lose it. Volume 5, not the overview, the rebuttal, the response document. Your new attempt is in bundle 44. It's in this document. Allow me a moment just to put my hand on it. Page 65, please. No, it's not. Sorry. It starts at 54. So you carry out a clustering analysis by a new method.
That is correct.
I just wondered why you decided to carry out the new method.
So there is still the concern about what is happening, right? What are we seeing here? And how do we sort of help ourselves understand? And so that is, from an epidemiological and statistical point of view, you think about different ways to model the data.
Would it be fair to say that the conclusion of this exercise is you don't actually see clusters, really?
Runs, yes.
Runs.
Runs. You do in a few of the organisms, but we don't see a lot of runs.
Yeah. So what I want to do is to move to a topic that has always confused me. and I want you to indulge me by just me setting out a scenario. Let's imagine that the reality is, purely imaginary, that some proportion of the infections that were observed for both environmental and non-environmental in the pediatric patients were brought in from outside.
Okay.
And when I say some, in all cases, I mean a non-negligible amount.
Okay.
And that some in the environmental were caused by widespread contamination of the water system. And that some were caused by gut breakthrough or colonized patients for the environmental group. And amongst the non-environmental group, some were brought in from outside, some were caused by line care problems, and some were colonized patients as well. So in effect, we have 7 different causes spread over 2 types of bacteria. Now, if that was the case, and I realize some is doing an awful lot of work in that paragraph, would this sort of method of looking for runs actually find anything?
So if that description of those 7 items was completely chaotic, in other words, there's no
I think there has to be a pattern.
Yeah.
I can't say some water and some CLABSI unless there is a pattern, because they have patterns in that we can see patterns if they're true.
So where we would see, we would likely see patterns is, for example, if, and this is, what you get with Pseudomonas, one type of organism growing in the tap. Or some contaminant in the environment and poor line handling, and they keep touching whatever that contaminant is. That's where you would see something in those runs, because you would get repeated cases of the same organism. But you would have also seen that in the sequencing if they were able to do a lot of whole genome sequencing, right? Because you'd see clonal organisms.
Yeah, but if we just look at the cluster exercise, what's concerning me, I suppose, it concerns me about pretty much everybody who's given evidence from an expertise point of view, is that often it is said, I can show yes or no whether something is the cause. Of course, is there really ever going to be one cause?
It is highly unlikely.
Yeah. And so if we go back to your bullet points on page 119 of 44 volume 1, what I'm just wondering about the previous statement about clusters, your work on clusters, and the Case Notes Review work on clusters, which they did through a qualitative analysis, is, in a sense, is it entirely possible they're just all right? Because they're all coming at it from a different direction, doing different things. So Professor Hawkey's approach is qualitative, but with very little material, just dates and wards. The CNR is qualitative, but vast amounts of data, which we can't see. And yours is statistical, just dates, really, nothing else, maybe. And actually, they all come at it and they just slightly miss each other. They're not actually contradicting each other.
Yeah, I guess this is what I would liken to the approach that I keep mentioning. If you model the same data with different statistics and you get the same result, that tells you something. If you get very different results, you're left with still a lot of questions and not a lot of answers. And I guess that's where we would be left. I don't know that these qualitative approaches are as comparable.
Right. If we look at the second last bullet point, overall patterns of BSI attributable to microorganisms that are environmental follow the same pattern as BSI attributable to microorganisms that cannot be attributed to environment contamination. Do they follow the same pattern in the children?
No, I would say I would change that to a similar pattern where non-environmental starts first, and I would say cannot be fully attributed to the environmental, because I don't think, and I don't want to speak for my colleagues, but I don't think any of us believe that any part of the environment cannot be attributed to some cases. What our understanding is that the entire increase was being attributed to, and maybe that was a misrepresentation given to us, to water, which is a very big stretch.
I'm going to challenge you on the similar.
Okay.
Can we go back to Bundle 44, Volume 5, page 50, please? Now, I'm going to look at the two charts. This chart has a point when the data is above the blue line and a point when it's below the blue line. The next chart, page 51, at the point before the increase, it isn't really below the line in a sort of true sense. So is that a difference?
Yeah, that's different.
And do we need to think about why that might be? Or do we just think for that added experience and think it's not important?
I think I very much appreciate that you want to think about that. I think it's interesting. And I think largely I ignored it because the focus, of course, was on increased cases.
It just occurs to me that we look at the non-environmental one and we start thinking about clemency.
Mhm.
I suppose line care generally can get better, but it generally gets better after it's got worse because you have to work at it to get it better. So I'm wondering whether a peak happening from the linear without a dip perhaps isn't that surprising if it's line care, because things just get worse for a reason we can't necessarily find, or a time, or reason, and then they silt it and it goes down again. And in fact, it drops below because they're really efficient. Whereas if you go back to page 50, if it's the environment and you put yourself into a nice clean environment for a short period of time, it gets better. Then, of course, if you don't manage that nice clean environment, it gets worse. And so are those shapes perhaps telling us a story about the direction of the change pressure in the two different types of microorganisms?
So they could be. I want to note that it starts decreasing in 2014,
Yeah.
which is before the move.
Which is confusing on that theory.
So I would say certainly that there might be something about the different microorganisms and the pressure on the microorganisms, but so again, I'm perplexed that water would be necessarily proposed unless there's something that happened at York Hill that we're unaware of.
Yeah, so we don't have any evidence of that. So I think this is a reasonable summary. They move into the new hospital, and there is lots of noise about ventilation in the new hospital. But there isn't really any discussion about water in the infection control team for at least a year. But there is lots of discussion about ventilation, and that's why there's a contrast, I would say. We also have, although we have the DMA Canyon report, which I think you've now read, full of anxiety about the water system, I'm wondering whether the existence of a drop below before the increase might well be consistent with, for a period of time, the water being cleaner than it was at York Hill. And that might suggest that the change to the buildings is the change of the drop.
So what I'm going to say is it could be a reasonable hypothesis.
Yeah.
What are your counterfactuals?
So counterfactuals are, you move into a new building, it's absolutely spiffingly clean, everyone's very happy, and they don't have any issues of bad infection management control in the single rooms. But that counterfactual is inconsistent with the clemency, with the environmental growth, because the environment's going up at that point. So if the experience in the single rooms is good in the new hospital, I suppose you'd hope it would be, you would see you wouldn't see the increase in the environmental at the same time as non-environmental is a decrease in the environmental. It's that contrast that I'm trying to explore.
Yeah, I see what you're saying. So you mean if it's line care there?
Then both of them would be going up.
And I guess I would say that is true, although I might say that a counter argument would be if it is line care
Yes.
and you go into a spotlessly clean hospital, let's assume it is.
I mean, I don't think it was, but we'll assume it is.
Let's just assume it was. Then they're not picking up anything from the environment on their gloves or wherever to contaminate the lines.
Yes, so you would only
that.
get non-environmental increasing.
Yes.
Right. So that's a different way of seeing it. Okay.
Yeah, that's a different way of seeing it. So that could be one option. I would be very cautious to describe everything that we see as that.
No, this is my concern is that I suppose as we learn in the inquiry about stuff, the absolutes seem difficult to understand. But you seem to have rejected the absolutes. So it's not all the water, it's not all the line care, it's not all the management, not all these things. Let's go back to the bullet points on page 119 of 44, volume 1. I just wonder about the last bullet point. There have been large reductions in incident BSI overall and by microorganisms environmental attrition at Queen Elizabeth over time, suggesting overall increase in the effective prevention strategies. I appreciate that was shown by the linear regression from figure 22, the chart, the line that's not on the chart. But is it a good idea for a panel of experts to say that when they know that the case notes review has as a principal conclusion that there were problems with infection prevention control in the hospital at that time? And that's not their clustering, that's their review of the evidence.
Yeah, and I think that it could have been better pointed out that even if we look at the new modeling of the data, the latest data, I can't say currently because we don't have data from current, the latest data we had showed, regardless of whether or not there was a problem in the middle, which I completely agree with, that things are better now than they were before. For example, if we take York Hill, they do have lower rates now than they did when they left York Hill.
I suppose the final counterfactual point before we move on to Aspergillis is this. There seems to be a view, which I wonder if you can comment on, that the two facts that Ward 2A and Ward 2B were fully repitted at vast expense with a ventilation system, new water pipes, considerable effort made to make sure the water was clean, including replacing taps and a lot of more work than perhaps even was expected. And now the rates are, for environmental and non-environmental, are low, in fact for non-environmental, lower than the trend. Whilst counterfactuals are important, the fact that you had to replace the entire ward tends to suggest the environment might have been part of the cause.
It does suggest that. I'm going to throw out a counterfactual that I do think is really important here. Once it gets a ton of media and press attention, then people are going to be pretty paranoid about how they look after lines and what's going on and prevention in a way they might not have been focused on before as well. So I think...
You think in the sense that we've got to remember that things will always get better anyway if you apply attention to them.
Yes. Yes, they will. And that's not to say that I don't think that refitting the water could have contributed to that, but I just want to highlight that when people are under a microscope, they behave in the way that they think is expected of them.
Right. What I'd like to do now, Lord, is move on to Aspergillis, which is my final sort of major topic. And then we'll have our 10-minute break for Rule 9 once I've done that. Right. I think we might run a little bit over. I have warned my colleagues, but I think I should mention that.
So what do you suggest?
I think I'll be going now until about 5:02, so we'll probably be looking at a 4:30 finish, I expect.
Right. So, sorry, I may have picked you up incorrectly. Are you looking for a break now?
No, I'm not. I'm just sort of
No.
brief warning my colleagues because I
Right.
discussed it briefly before lunch, and I wanted to make sure they saw where I was.
Dr. Drumright, you're quite comfortable?
I am.
Yeah.
Thank
So
you.
what I want to do now is to move on to Aspergillis. Now, I suspect what I have to do for Chapter 8 is talk to Dr. Agarwal, really, because he would do the work.
So, yes, but I am happy to answer the questions about the new modeling.
Yes. So what I want to do is briefly look at Chapter 8, just to get context, then look at the new modelling, and just for completeness, look at the new modelling that we asked you to do, and then ask you where it takes us. So if we go to 44, Volume 1, and we go to Chapter 8, which is on page 123. Now, obviously, you didn't do the analysis of the imaging. You're nodding again.
Yes, I did not do the analysis of the imaging. I did not call any of the cases. That is all Dr. Agarwal's
So he gave you counts.
Yes.
So in fact, if we go to page 125, what we see in figure 23 on page 125 is the counts for the adults by year.
Yes, I would have to double check that is the final set of counts I had when I analyzed the data.
I think you made one change, but now I can't remember which year it is, but it's the counts at the point he wrote the chapter.
Yes.
Yes. And we see adult south is blue, and apart from 2018, well, in fact, before 2017, we have years that are above 1, but otherwise it's 1 for every year through the data field. And then adult north is in orange, and adult BMT is in green. And I suppose we should also notice the bars that he's put at the top to show when they were in the hospital, the green ones.
When they were in QEUH.
Yeah.
Yes.
And our understanding is that from 13th of June 2018, they were in HEPA filtration, positive pressure to the rest of the hospital, 6 air changes an hour in Ward 4B. But when they were in there briefly in July 7/15, they were not in such a bespoke environment. Now, he didn't calculate a rate. Is there any particular reason that you know about, or should I just ask him why he didn't calculate a rate?
I think you should ask him. I think my understanding is that the numbers were very low. So
if we go on to page 128, he's plotted the pediatric meta-oncology rates, similar style, only 1 column, and he's plotted the locations within the children's hospital above. So we have a bar between June 15 and September 18, showing they're in 2A and 2B. And then we have the bone marrow treatment patients in 4B, and the inpatients, and indeed the outpatients as well, in 6A until 22, and then everyone's back in 2A, 2B. And I'm assuming the same issue is the reason you didn't plot the rates.
that is my understanding.
Now, I asked Dr. Mumford and Mr. Mukherjee to calculate rates, and they did that. I'm not proposing to take you to them because you eventually did your own rates.
I did.
And since, although I think NSF have some criticisms of Dr. Agarwal's methodology to construct these rates, he has to get some credit for constructing some rates. No one else has done it. So we'll use your rates, or the rates that you constructed, in the calculations in the supplement, in the response document. So it's volume 5, so bundle 44, volume 5, and we go to page 66. Now, what I wanted to do with this was to firstly check in with you about methodology for constructing these rates.
Yep.
Because I suppose we could end up down the same rabbit hole as we were before with the BSI. Has he effectively followed the same used the same occupied bed day data.
That is correct. That
Yeah.
is the occupied bed
Yeah.
data I had.
So if there is a mismatch, it's the same mismatch.
Yes.
Yeah. But with that in mind, and we look at, we should probably go and look at a particular chart that he produced, because it's an annual chart, which is on page 69. And I suppose the reason I wanted to go down, well, it's a different style. It's the same, roughly the same data as page 124, which we looked at before. It's the 3 different parts with annual rates.
Yes.
Now, from onwards in both exercises, you moved to monthly rates. Why did you move to monthly rates?
So again, this is a preference for data analysis. When you remove data, so when you go from month to year, you're removing information that is valuable and you're removing power. So the reason that it's graphed on yearly rates is because that was our understanding of what was asked for us, as well as the monthly, which is my preference.
But the original count was just a count, so it didn't matter about power. So it was done
That's
annually.
right.
Yeah.
That's right.
But you felt by moving to monthly, you get power.
Yes.
Now, is there any suggestion, if we move on, for example, to look at what could be described as a confusing graphic on page 71, the very number of 0 months.
Are you looking at the table?
I'm looking at the chart.
The chart.
I mean,
yes.
the table works as well, actually, the point.
Yes.
There are lots of 0 months. Does
Very
this
many.
actually get unhelpful at some point?
Not necessarily, no, because if you ignore those 0 months, you're losing information again. So remember we talked about the negative binomial
Yeah.
GLMs. We can use those with this. And for example, what we actually see in here is not that any one month, with the exception of that peak in the middle, is really gaining a whole lot of cases in a month, right? We see 1, 2, or 0 cases per month.
Yeah.
Always. It never goes above 2. But what we see later on, and we see our curve, is when we look at the whole set of data, we do have a significant linear increasing trend, very slowly increasing, but increasing. Our 0 months are just getting fewer.
Right. Well, if we go on to page 73, we see Aspergillis. This is you going back to your negative binomial
Yes.
GAM plot.
Yes.
So, I mean, at one level, this is difficult to understand. The dots are
Mostly
when
zeros.
the human eye sees the dots that are on the line, but of course you could remember there are lots below the line. So what's this chart showing us?
That chart is showing a, and this is, I just want to make sure, this is, so I want to make sure that everyone's aware, this chart right here is what you asked for, where we cut up the data.
No, this is in the
Oh, is this the
response
original?
document. Yeah.
This chart is showing that there's a linear trend. Your smooth line is completely over the top. That's why it looks purple. And I believe, and I want to double check. Oh no, the p-value. Let me just double check.
It says at the bottom of the page, there's no significant change over time.
No significant change over time.
So that's the adults
showing.
of the Queen Elizabeth.
Yes,
no
that's the
change over
adults.
time.
Thank you. The adults have no change. It is a flat line. So it is saying that adults basically have Aspergillis largely at the same rate over this whole time period.
Yeah, and if we look on the next page for the other hospitals that you've got data for,
it's also flat.
It's also a flat line.
And they're roughly the same.
So in a sense, that didn't really tell us anything, other than there's not really a trend.
What it tells us is there's no difference between these groups.
Yeah. Even though some of them have ventilation that's better than others, it's not making any difference.
It's not making any difference, yes.
Then we go to the pediatrics, that's next page 75. We have on page 75, figure 5C1, the monthly counts. And then on page 76, we have the annual ones.
Yes.
Next chart, next page. And that's 5C2. And so your comments, I'm assuming, about the zeros and the binomials apply the same here.
Yes.
Right. Now, over the page, you plotted the pediatric Aspergillis on one chart.
Yes.
What does this GAM negative binomial line show us?
And I apologize. This is when we went to the adults. I thought we were going to talk about pediatric.
Yeah, totally.
What this is showing is a very, very gradual increase over time that was statistically significant.
Is it possible to see in this chart whether there is either any change point at all or when that change point is?
So this chart right here suggests no change point. And there's a subsequent analysis in the questions you sent to Mr. Mukherjee and I, where we don't see a significant change point. But I did, as you are aware, some other modeling to sort of impose a change point. So that's in those data. I don't know if you want to go there now.
Well, what I want to do is just to walk us through these slowly, because I suspect we're going to get nowhere in the end, but I want to just see where we get to.
Sure, no problem.
Of these two, the linear and linear smooth, are either of them more significant than the other?
No, I believe the linear smooth isn't significant because it's matching the linear. So there's.
What about the feature on the right-hand end where it starts dipping
down? That little
down?
dip down on the end, yeah, it's not going to call that.
And if we go on to the, I think this may be page 80 is where you imposed a change point. Is that way?
No, this on page 80, I took. So this is based on annual data now. I took, because that's the only data I had from Mr. Mukherjee.
Yeah.
I took his data and I plotted it, and I took our data and plotted it, and that's what you can see. The hat is the red and the is the blue. And it was just to demonstrate that even when we have this wildly different number of cases at the very end, most of our case numbers and rates are about the same.
Yeah.
But at the very end, they're wildly different, and we're still seeing the exact same trend.
So you wouldn't think there was in the pediatric. Well, let's go and see what Mr. Mukherjee did, because I think you need to comment on that, so that, and then ultimately he can comment on you. So we go back in the same document. Well, actually, no, let's not do that. Let's go look at what I asked you to do first. So that's volume 7. And I think I've obviously been told quite carefully by you what you think about chopping up data points. But we should probably look at page 55. But let's not do that. Let's look at page 53. So I asked you to look at the Aspergillis at York Hill by itself. And what's happening here?
So what you see is your blue line is always your linear and your red is your smooth. And in this case, we do see this increase in the smooth line, but that line is not statistically significant.
So we should put it to one side.
So we put it to one side, and what we see, and if you can scroll down, it's underneath. I believe that trend was not significant.
Over the next page, actually, 54.
I think
the trend there isn't significant.
Is not significant.
So even the blue line isn't significant.
No.
No, right.
So what that says is there's
no trend.
Yeah.
But in the context of the longer overall gradual trend.
So no trend in that.
So that bit of York Hill, but we've got to remember that the whole long sequence has
does have a small upward trend.
Right. And then we go to the similar short chop for York Hill on page 50, not Queen Elizabeth on page 55. Again, what does your GAM exercise tell us here?
So again, the smooth line is not significant, so we should ignore it and go with the linear trend, and again, that's not significant.
So the only thing that's been significant is the long trend over the whole period.
Yeah, let me just, yes, over the long period.
And in fact, helpfully, you provided that on the next page, at page 56.
Yeah, there
Right.
it is.
So let's look at Mr. Mukherjee briefly. He decided to do a linear trend lines for Aspergillus.
A linear regression trend line, yes.
And he plotted that on page 42. And I understand you have a little bit of a concern about his confidence intervals.
Yes.
So what's your concern about figure 1 on page 42?
So, oh, interesting. His confidence intervals are showing up a little bit. His confidence intervals are awfully tight.
You mean they're very close to each other?
Yes. So when...
I wonder if we could zoom into about half the page just to make it a little bit easier for us. Yeah.
When you have that variable of data,
Yeah.
your confidence intervals get pretty wide. When you chop up your data and you reduce your power, your confidence intervals get pretty wide. I tried to model what I saw here. I could not replicate these confidence intervals.
So you think that
I'm just
you would
not.
disagree with Mr. Mukherjee and say that the idea that there's a step change, sorry, the idea that there's a step change at the change between the buildings doesn't have any statistical significance.
Well, that and the confidence intervals overlap, right? Do you see right there the yellow and the blue? So I think it's largely the modeling, I would also argue, is not correct because this is using not a GLM, but a linear regression.
And so it won't deal well with the zeros.
That's right.
Right. Let's take that off the screen and go back to the HAD report itself.
And just to highlight again, if confidence intervals overlap, then that is a possible point. So they possibly could have the exact same point estimate.
Yes, understand.
Yeah.
Can we go back to bundle 44, volume 1, page 128? And I suppose where I'm sitting at is I'm stuck and I need your help.
Okay.
So at the end of this page, Dr. Agarwal, I'll ask him about it too, says table 19, bottom of page 128, shows the breakdown of cases by location throughout the period the pediatric service was based on wards 2A, B, RHC, and during the time of relocation to 4B and 6A. The annual total number of cases in the pediatric service varied from 1 to 7 in 15 to 22, compared to 0 to 5 in the years prior to 15. No trends are seen over the time by location when the service was split between 4B and 6A. And of course, you went ahead and using what bed day data you could find, you conclude that there's no statistical significance between the two periods. In fact, there's a gentle trend upwards, but that's all. Obviously, this is a public inquiry, and we're not necessarily answering the question of is there a statistical significance in this data, or should some scientists reach a conclusion? We've got to work out what to do about ventilation that doesn't meet guidance. So what role should this chart, and I recognize it's only numbers, not incidence, and the incidence is not statistically significant. What role should this chart play in our deliberations of does it matter whether you follow guidance or not?
I want to be a little bit careful about this. I'm going to back
Absolutely.
up and say I might not answer that question directly. There's lots of reasons to follow guidance.
Yes, of course.
And it stretches outside of this inquiry, I would suspect. I could be wrong.
Yeah.
The question of, is there a problem being caused by ventilation that doesn't meet guidance, I think is more of what this is pointing toward. And it is suggesting maybe not, although again, we should probably understand, and I don't know if you want to talk about this when we talk about my modeling of where a change does occur.
Well, I
in
was
the
going to
data.
come to that in a moment, but I just felt that
Yeah,
The question could actually be asked in both ways round. So you could ask the question, and maybe we come back to it after look at the change, is does this piece of information help us to determine that you don't need to worry about the ventilation being below guidance? Or does this chart help us determine that you do need to worry? So it's sort of opposite way round. Does it help either way in proving that we need to worry about ventilation system?
I'm going to not directly answer that question again and give you a different plausible answer, which this information plus a lot of literature out there, which I know a portion of, which shows that ventilation at the rate we think doesn't have the impact we think and doesn't do the things we think. I think what it suggests is there is a lot of need to explore and understand what is going on with ventilation and what should be proper ventilation in healthcare settings. And I'm not sure that current guidance meets that. I'm not sure that this is the right way. What I am suggesting is that we know very little about ventilation, and that's to keep going on with that's probably not a great idea.
Okay. Well, let's go back to your calculations on change.
Yeah.
So 44, volume 7, page 65. So it's sort of section 3 of your report.
And this is our response to you now, isn't it?
Yes, it's in the well, this is your document.
Yeah. So if we, I mean, I can summarize it if we don't move along, but there is a table.
Yes, if we go on to page 68.
Yeah, so in this table, what I did was I was curious if we if we look at my model, okay, so we put aside Sid's model and we look at a linear change model, which is the one we saw before, the GAMP model, that it's increasing slowly. And we tell the model it has to impose a break somewhere.
So it's a bit like when I gave you the questions.
Yes, but I told the model to do it based on the data.
Yeah.
It picks the point in 2019, not at the move.
And how do we see that from the table?
Okay, so from the table's not showing you that. What the table is showing you is comparability in models. And so I throw in a model in there that I know is no good, which is the constant assumes nothing's happening. And that model has an AICC weight that is quite low, and that's showing that's not comparable. But if you look,
so you're comparing a particular model to the data.
We're comparing the models to each other.
To each other, right? Yeah.
Yeah. And so that model is completely out. But if we look at the linear change model, which means there's a constant linear change over time,
yes,
versus the step change model that picked a date in 2019, those models, you can see that the step change model is ever so slightly better, but at 0.11 in the difference, right? That's not considered significant. You need a difference of 2 or more to say a model is better. So what that is saying is those models are equally plausible. So what I would say to you is either we have a constant increase over time, or in 2019, and
Julie, I think the previous page, July.
The month, July 2019, there is sort of this step change increase.
So if we take all these various attempts using Dr. Agarwal's data, where does it leave us? What does it tell us?
Honestly, I'm going to go back to what I said before. It tells us we don't understand enough about ventilation. Do I think there should be, just my own opinion, there should be unventilated or nearly unventilated wards? Probably not, right? You don't want to close building without ventilation. Does that seem to have an impact on Aspergillis? The data are suggesting maybe not. Maybe there's something else going on. Is Aspergillis the best choice? Maybe not, because COVID would look very different, presumably. And so I think that there is a lot of work to be done. You know, and if you go then to the literature and other things to be done on actually what's proper ventilation, that does not answer your question about should hospitals not follow guidance. I think that's a loaded question that I will refrain from answering, because I'm not sure anyone should not be following the guidelines that are there. I guess I would say, how good are the guidelines? And I'm not sure. The data suggests to me that it doesn't have an impact on something like Aspergillis. But again, like I said, it would probably have an impact on something like COVID.
On that topic, I mean, I put this to you that Aspergillis, was quite close to being too rare to do this work on.
Potentially.
And rarer conditions like Cryptococcus, we wouldn't be able to do this on that, would we? You're shaking your head.
Yeah, no, you need enough data, and I think that's why Aspergillus and these patients particularly for patients that get in these types of infections get Aspergillus.
Yeah.
You had to pick an infection that might be representative.
And it has to have enough cases.
Yeah.
And this is quite close to the margin of not having enough cases. Right. Now, I think we're almost at the end. The final questions, before I see if my colleagues have any questions, relate to the design of the whole exercise and your role within it and your duties as an expert witness. So, if we look at HAD questionnaire 1, so it's bundle 44, volume 2, document 1, page 28. It's actually question 16. We asked you about the contemporaneous epidemiology, and I listed a series of pieces of work. These first 3 are by HPS on page 28. Over the page, we have Dr. Harvey Wood, Mr. Kennedy, Miss Harvey Wood again, Dr. Kennedy and Jennifer Rogers, and over the page, that might be the end of it. And in all cases, you responded, it was not our instructions to review and critique the management of infection control. These reports aren't about the management of infection control, are they? They're about epidemiologists like you or people who are trying to be epidemiologists like you, trying to work out what's happened.
Sure.
So why didn't you look at them?
So that was not part of our instruction. Data was part of our instruction. And again, I will reiterate, I would have to go back, that list that you have of what you call the data dump, I'd have to go back and check that that's even in my folder. It seems like a long list of items that I'm not sure were in there.
Because even if it wasn't there, you know from your instruction letters there's a public inquiry.
Yes.
Amongst other things. And so you must be able to assume or infer that there is a level of interest in this. So we go back and look at the letters. So that's, if I won't go to the letters, but would you have known about the existence of the independent review?
So,
I mean, I realize you're in Washington on the other side of the world, but would you have known about the existence of the independent review?
No.
No. The oversight board?
No.
But you knew about the case notes review, albeit you didn't read it.
Yes.
Because I'm wondering whether there's an obligation on an expert witness instructed for court proceedings, amongst other things, to inquire when there's something as significant as these instructions come through, to produce a report that may be used in court proceedings to say, you want me to design and deliver an epidemiological data study. Has anyone else tried something? I might have a look at them first. Why wouldn't you want to do that?
So it is my understanding, and I was brought in late, and so I would ask that you confirm this
Yeah.
with my colleagues, that there was a desire for an independent, not having reviewed other items necessarily, assessment of the data. I was brought in just to look at the data and analyze the data. I was brought in rather late, so it was a lot of rapid work. Having been on the other side of the United States, I only became aware of the inquiry, which I know my colleagues had been aware of previously, when I started working on it.
Because I appreciate that not being encumbered by other people's biases and thoughts would be an advantage. But the counterfactual is that you just accept the data you're given. You fail to realize that there is a national database of occupied bed day data available according to NSS. You don't know why the water is said to be, by some people, contaminated, or what the inadequacy of ventilation, when that changed. And therefore, that being unencumbered by the biases of previous people actually results in a lack of value to your exercise because it's not grounded in any form of reality. Now, I realize I've phrased that in an unfair manner. Is there anything in there that has some that you would accept?
I think that being able to, if knowing what I know now, I did this exercise, I probably would have still started with an unbiased analysis. And then, given all the time in the world, which we didn't have, been able to read the relevant items and then ask questions about comparability and other things like that. And the reason that I point that out is because as I read items, and I did not read them all, there are many, many bundles, but I read items that largely you and your team pointed me to. I felt that there was a biased approach to begin with, that water was to blame, and we were going to somehow prove that. There were no counterfactuals that I saw in the items that I was directed to. Now, that may not be a correct assessment of what was
But
happening.
you weren't directed to any items. The only document.
No, by you and your team.
But you were directed by your original instructing solicitors to the HPS summary review, which you didn't read, the case notes review report, which you didn't read.
But I was not directed toward those.
Well, Chapter 4 criticizes the case notes review, and you signed the report, so you had access to that, and it's full of counterfactuals. Chapter 8 is full of lots of things. And the HPS summary review, I don't think it's full of counterfactuals, but it's full of detail. So how do you, one of the questions Ms. Jester I should ask this is that you've willfully ignored data in order to design the study. How do you respond to that?
I would say that that's an unfair statement because I did not have access to those data. I was given a data set by an NHS entity on NHS data. So maybe I naively trusted them.
Could I, sorry for asking you to go back. You used the word biased a moment or two ago. Could you just tease that out?
Yeah, so I think when you approach a problem like this one, so for example, you're asked to model data and determine if you see any significant trends. If you are told that you're modeling data to show that water is a problem, that's a biased approach, as opposed to saying, all right, you want to know if there are trends there or not, I'll let the data tell me if there are trends there or not.
So I may have picked you up wrong. I thought at the stage you were instructed, you had understood that somebody else had adopted such a biased approach.
We had understood that there was, yes, an approach to say there was a belief that water, and this was our understanding, which I understand now is not what was being argued, that water is causing all of the infections.
And where did you get this information?
This is from the discussions that I joined later in meetings with the CLO team, that there was this idea that water was causing a huge amount of infections.
And when you say the CLO team, do you mean, who do you mean?
Dr. Ribello is who we originally met with. And again, this could be my interpretation, but there was a lot of talk about a lot of this increase in infections being caused by the environment.
And was it specified beyond a lot of talk?
Could you
I mean,
clarify?
who was doing the talking?
So I am not confident that I can recall exactly who was always at any meeting or saying
No,
there
who
was.
who?
It wasn't me.
No.
Who
Bad
was
question,
talking
bad
about
question. Who were you told was adopting this biased approach?
I'm not sure that that was clear.
Mm-hmm.
It was sort of an excited kind of idea around it, and I'm actually now not sure that that's clear who was adopting that approach. But the idea was, so the first idea we had is that's kind of crazy, because if you had dirty water, say the water was terribly dirty, it's not going to cause all your infections. And so then, and we never had the idea that it couldn't cause any. So we were really looking at, is this, causing a significant problem? And the extent of the dirtiness of the water was not clear either.
A couple of things. I think I heard you say, but I may have misheard, that when we as the inquiry unit supplied you with material, we didn't supply you with counterfactuals. Did you say that?
I'm not sure I said that. I think that I said that I wanted to introduce the concept of counterfactuals.
We brought Jennifer Rogers' statement and
Yes.
the CABSI to your attention.
Yes,
In
absolutely.
the first questionnaire.
Yeah, I don't believe I said you didn't
I
give
may
me
have misheard.
counterfactuals. Yes.
I think
because
the point I want to just tease out is that I think it's proper to put to you the position taken I realise you had your letter of instruction and you've explained to his lordship what was put to you in meetings. And I'm wondering whether it might be appropriate to put this to you. What's your view of the suggestion that that none of the BSI that you have had in your data set were caused by the water? Is that something you would agree with?
So I want to step back from the word cause, just because I'm an epidemiologist.
Absolutely. Would you like to do associated?
I'm going to replace it with potentially attributable.
Okay.
And I would say that I don't agree with that. I think that some of this is, if, as there is evidence, there were growths and taps and things like that, it is probable that some of the cases, that is where they picked up that microorganism,
And I suppose the final
or
question
possible.
is to think about the intersection between statistical epidemiology, which you've been describing, and everything else that Bradford Hill talked about, the rest of epidemiology. So we've heard evidence from a lot of people who were involved in the hospital from before it was built, when the water was filled in 2013, who managed the water system, who were doctors and nurses in the various departments, who were in the infection control team, and given its dysfunction on both sides of the argument, in senior management, both on the clinical and management side. And we've reviewed the investigations carried out by the Health Board in 2018, by Health Protection Scotland that year and the following year. We've got access to all that material. And I do appreciate that you've been very careful to keep your answers tied to your data. And I do know that Professor Hawkey will have to discuss whole genome sequencing, and Dr. Aguilar will have to discuss antibiotic resistance. So that sort of has to get passed slightly. But for the inquiry, is there anything wrong with going back to Bradford Hill's postulates, looking at them all, and coming to a balanced conclusion about association and causation, which gives epidemiology, statistics its place, but also gives experience, interventions, all these things their different place in the decision-making process? Is there anything wrong with that as a way of proceeding?
So there is nothing wrong with using it, as he stated, as assistance in trying to decide. He was very clear that it doesn't prove cause, but rather it's guidance to epidemiologists. There are other models of guidance for causation that should be explored as well.
Right, but the point you're saying is it's not about proof, it's about association, it's about connection.
Yeah, I mean, you know,
You can't prove a connection with epidemiology. You can give a strong indication or a weak indication, but you can't prove it.
I would agree 100% with that. This is retrospective data. We know maybe the data quality isn't what ideal. There are lots of questions about the data, and so it is very difficult to say that there is cause here. I don't think without something like whole genome sequencing showing clonal, sort of
For which you might need
transmission.
appropriate samples, and we can discuss that with people.
Exactly. There is no way you're going to prove cause.
Okay.
But this is weighted evidence in epidemiology, right? Is there how much do we think it is likely something's attributed? And I will go back to why I like to use different models, why I like different data sets around the same concept, because if everything keeps pointing in the same direction, and this is a very Bradford Hill kind of concept, that suggests that it is more likely that that is true.
Well, thank you very much, Dr. Drumright. What I need to do, my lord, is to see if any of my colleagues, those watching remotely, have any further questions. If we might rise for 10 minutes.
If I may, I might ask one question, which is intended to be entirely open and not reflect on anything. And it certainly is not intended to be open to any adverse inference. You, as Mr. McIntosh established at the beginning of your evidence, you signed a declaration which included stating that you understand that your duty in providing written reports and giving evidence is to help the inquiry. Yes. Now, when you were instructed, and if I can, by CLO, how did you understand the word help?
So I understood that as giving an objective response based on the data. And what I said to the CLO was, if I agree to participate, what I see is what I will show, regardless of whether or not that's popular, right? Because they're asking you to work as an independent witness. I know that when you have a setup like this, people might have their own opinions of what they want to see, but I'll only report on what I see in the data, regardless of what that is. So my idea of helping is objectively reporting what I can see in the data. As things evolved and we, came under Mr. McIntosh's team, I was more than happy, as Mr. McIntosh knows, to perform analyses, go after features. When I found out about other data I was very interested in, I requested, probably at his annoyance, data sets over and over, because what I wanted to do was, now that I knew there was much more data, model that data in the same way I modeled mine to see if there were differences. So very interested in sort of helping to understand what the data are telling us.
Thank you. Well, what we'll do now is take a break for, I would anticipate, no more than 10 minutes
Okay.
to allow Mr. McIntosh to check with the room whether there are any questions that need to be asked. So can I
Great.
invite you to return to your witness
Yeah.
room?
one question which I need to ask.
Apparently, one more question.
All
So
right.
what happened, Dr. Drumright, is I forgot to ask this question, which relates to the NSS review, the Aspergillis data.
Okay.
So if we can just go to the document, it's 44, volume 3, at page 222. So this is, and it doesn't necessarily interact with you, but it might do. So when Ms. Cairns responded to the HAD report, she didn't have access, because of timings, to Dr. Agrawal's calculations. She then got them, and then she produced this document. And if we jump onto the next page, just to see if it's not very long, and the executive summary is on page 3, and I might just, well, page 1, I might just suggest that you quickly glance at that, because I want to ask whether you've reviewed this document and what your response is to it.
So I don't believe this is a document that I've seen yet.
Right. So the point that is suggested, if you go to the next page, is that there seems to be a criticism advanced by NSS that Dr. Agrawal's data doesn't sort of fully meet the best standards of carrying out epidemiological analyses in terms of case definition and such things. And if we go on to the next page, if you see on paragraph 6, they discuss his choice of deduplication process, where he appears to have deduplicated by the admission episode rather than by 14 days or for something.
Well, yeah, so.
And what I was wanting to ask was, in the sense, I appreciate that you didn't do his exercise, he did it. But if we assume for a moment that his approach is, to some extent, criticizable on the basis it doesn't deduplicate in the way NSS would expect, or has a case definition that's perhaps a little bit softer than you might want, what effect does that have on the value of the numbers that he's producing?
So the first thing I will say, again, I will have you put this to him, but
Yes.
I work in the area of fungal infection. And of course, with Aspergillis, you cannot just rely on the lab data. And that's all he had. So the case definition, they can criticize away, but if you don't have the complete set of information, you can't set up a case. And this was my argument about data should be standardized. Somebody decided on those cases or not. So what will happen is you will call more cases than are actually true Aspergillus cases in that instance, right? So he won't miss any, but he will get too many. And then in terms of deduplication, I would ask them to go back and look and make sure that they think there is a 14-day criteria like there is for bloodstream
I
infection.
mean, I did wonder whether
that doesn't.
Aspergillis is different in that respect.
It is very different because treating a fungal infection takes a whole lot longer than that, and it's just far more complicated. I would be incredibly surprised if that was their definition and perplexed at who proposed it.
And I mean, I can ask you this general question because it's something I've been adopting as a principle, and perhaps Dr. Agrawal's work is the extreme example. From an epidemiological point of view, do these sort of criticisms of studies, case definitions being softer than they ought to be, deduplication not being complete or not being entirely clear in people's minds, do these knock out studies completely, or do you still have to use them a bit?
No. So these are your limitations in a study, and they limit the conclusions that you can draw, but they do not knock out a study.
Okay, I'm going to leave that there, glancing over at my colleagues. Thank you, Lord. I think, Dr. Drumright, that's all the questions I have for you. Thank you for your assistance over the last few months.
Can I add my thanks, Dr. Drumright? It is very clear that you have done an enormous amount of work, no doubt in preparing the report with your two colleagues, but also in engaging with the inquiry. And while your evidence is only part of a great deal of other evidence that we've heard, it does appear to me that that process of engagement has been productive. And in addition to just thanking you for your whole contribution, can I highlight that? But you're now free to go, and I don't know if you're traveling far, but safe traveling.
Thank you very much.
Thank you.
Now, I'm sure legal representatives require no reminder, but notwithstanding that, can I remind you that we'll be sitting at 9 o'clock?
We won't, my lord. We'll be sitting at 9:30.
Oh, it's 9:30?
There was an outbreak of enthusiasm.
I'm glad I raised the matter.
There was an outbreak of enthusiasm in one of our notes, which did say 9 o'clock.
Yes.
But the important people in tomorrow's evidence, that is the witness and Mr. Coral, think it's 9:30. And in fact, 9:30 would be more than enough time to get through Ms. Harvey Wood's evidence before Dr. Agarwal.
Mhm.
And so it doesn't have to be 9 a.m. I'm sure that will be well received by my colleagues.
Right. And the timetabling is Miss Harvey Wood
For
at
around an hour and a half,
9:30,
yes.
with targeting Dr. Agrawal at 11 o'clock.
Yes, that's the
Right.
objective.
Well, I'm glad to have been corrected, and I wish you a pleasant evening.